Oh, hi, everybody. Thanks so much for joining me again. We just got a short one today of an interesting chest X-ray that was sent to me a week or two ago by one of our doctors on the floor, Dr. Mabuza. So I just wanted to thank her for that. And yeah, so this was quite an interesting case that they had come across. It was a referral from one of the local district hospitals, and the patient had been sent through. Is an elderly gentleman. Just obscure his details here, for the sake of privacy. And the patient had come through with a history of shortness of breath, a 70-year-old male. Yeah, he was struggling to maintain his sats on room A. He had been sick for a little while, and they were a bit worried as to what was going on. And then I think they did an X-ray at the hospital and felt that there was something quite wrong, and then sent him through to us. Yeah, so we then had a look at the patient, and the first thing you would have noted was that he was quite thin. He was struggling a bit. He obviously had signs of a COAD. It's what we would call a pink puffer. So quite thin, breathing quite rapidly, and not really, somebody who you would expect to be doing well in the respiratory department, if we can put it that way. So anyway, he started experiencing severe symptoms about a month ago, and he slowly but surely deteriorated. And about a day or two before presenting to the hospital, his condition got much worse. And what we can see there is that we can actually see this. Well, let's try and draw it out. It might be easier for people to see. Yeah, let's try and get that. So what we can see on this particular X-ray, I mean, of course, we could go through the whole X-ray. I'm not going to stress too much about it because we've got quite a bit to talk about. So if we can see our lung markings posteriorly, because this, I'm guessing, is the posterior part of the lung that we're actually having a look at, you can see it actually goes across there, and it's going across there. So that's where the lungs collapsed over there. And if we have a look here, we can actually see the anterior fold of the lung. So it's a bit closer to us. And, we can see that as we follow the lung markings, we come just till about there, and then we can't see any lung markings beyond that. And here we can see what look like fluid full fissures as well. So these that you see here, so these are present in both the posterior lobes and anterior lobes, and you've got these fissures in between your lung lobes and things like that. So that's what we're seeing over there, a bit of fluid that's present over there. So what we have is a rupture of an emphysematous bullae that's gone on over here. So basically, this entire area was just emphysema. If we had x-rayed him probably 2 or 3 weeks before, we would have just found signs of emphysema over here, So you would have probably have had atelectasis, maybe Bullae. You would have had a patient who was still struggling. And then, of course, one of the Bullae just exploded, just ruptured. That's about it. And so we ended up with this. I suppose you could almost call it a spontaneous pneumothorax, although it really isn't. If you follow the lung markings, again, you can see there's fluid everywhere. You can see there's the hilum is very prominent. You've got these very prominent vessels that are coming out over here. So, and given the shape of the heart and the thinness of the mediastinum, you can see he's had chronic obstructive airway disease for quite some time. And, there's evidence of lung fibrosis as well. I think if we have a look there, let's just get it in another color, sorry. Let's just get this here, so just so that we can see. So you can see there's a bit of tenting of the diaphragm that's going on over there. This diaphragm, it's a bit difficult to see, but you can see it's not exactly 100% regular, although that could be due to the bullae as well, or the rupture that's going on over there. And if you had to look at I suppose we'd have to call it the healthy lung in this case. You can see there's quite a bit of prominence of the pulmonary vessels. You can see the vasculature is very easily visible. There's areas of possible collapse, where you can see that the lung is struggling a bit compared to other areas. And this is all, again, signs of emphysema as well. So, when the history of the patient was saying did have a long-term smoking history. He had worked in the mines for a long time as well. So this unfortunately had all affected his lungs over the years. And even though he was no longer working for, I think, about 15 or 20 years, but to have made it to his 70s as a miner in South Africa, that's quite something. I mean, I had also worked in a mining area for many years as a general practitioner, and I can tell you most of the guys who worked in the mines, by the time they were 50 or 60, they were already on their way out. They had suffered so much of damage to their lungs and their bodies and things like that. It was quite sad to actually see what had happened to them, and how they had actually succumb to look after their families, and it just shows you the incredible lengths that human beings will go through for their loved ones. And yeah, it's quite heartbreaking actually when I think back to some of those gentlemen who used to come, such wonderful people. I would often look at myself as the doctor. You're in a privileged position. You're working with your mind rather than with your body. Here you have these men who have given their lives, given their bodies, given their all. They've literally broken their backs to feed their families, and I had a great sense of thankfulness, to them, and to God Himself. It doesn't matter whether they believe or not. I'm just giving my own personal opinion. That I was never in that situation. I mean, I felt very privileged that I had never been asked to go through something like that. I couldn't imagine what it was like, but it just shows you the toll that it can take on somebody's body. So so anyway, getting back to the story here. So the gentleman then of course was doing a bit better on oxygen, but the question then arose, and the reason why the doc had actually asked me was, the question was, now, do we put an intercostal drain inside here? And the answer to that, from my point of view in the emergency department, is for cases like this, no. You don't put an IC drain in here, not because it's not going to help the patient, but simply because we don't really know what's going on in the rest of the chest, and we don't know what's attached over here. So once you stick in an IC drain, let's say you do put one in over there, there's a possibility that you're going to create, a permanent drainage fistula, if I can put it that way. You're basically you're never going to be able to remove that drain, because the patient's going to become dependent on that. They're going to need that all the time. They're always going to need air to be removed from there. So the best thing is just to let this area just consolidate, just collapse, and let the rest of the lung just take on. So the answer is definitely no. Now, in some cases, if the patient, there is a possibility of re-expansion of the lung, and there is a possibility that the patient could undergo some sort of improvement, then cardiothoracic sometimes does advise us to put in IC drains, but this is only after consultation with cardiothoracic surgery, after CT scans of the chest and things like that. So the question is, in the emergency department, what do you do for these patients? So a lot of the time, because they have chronic obstructive airway disease, your first thing is, of course, to put them on oxygen. And the truth be told, 90% of them post-discharge. So they'll probably be admitted for a few days, treated for any underlying infections. Their lung function will be improved the best that it can in hospital. But most of them will be released on home oxygen, because there's not much more that can be done. So that's the first thing that you do, is that you give them oxygen. There is one little caveat in that as well, in that you don't want their sats to go too high. So most of them who've had chronic obstructive airway disease for a long period of time generally actually get used to being hypercarbic and hypoxic. So in other words, they've got this increase in carbon dioxide in their system, and that carbon dioxide is actually what keeps them breathing. So that high concentration of CO2 is telling the midbrain, okay, I need to breathe, I need to breathe, I need to breathe. I've got too much of carbon dioxide here, please allow me to breathe. And that's what will happen. And as soon as you decrease that, in other words, you push too much of oxygen into the system, and then you start to remove the carbon dioxide, that driver of the respiratory center is gone, and now you've got a patient who basically stops breathing in front of you. So just remember that. Try and keep the saturation between 88 and 92. I wouldn't go higher than that in these patients. So very often they just need low flow oxygen. It just gets them a bit, it just makes them feel a bit better. It's a horrible feeling to be hypoxic, and this is now when they've gone below their normal threshold, what they are normally used to. You could, of course, give give a bit of cortisone, antibiotics. You just want to open up the lung a little bit, maybe to reduce the inflammation that's going on over there, allow the airways to expand. If it's a very severe case of COPD, I'm not talking particularly about this patient, if it's a particularly severe case of COPD, you may want to consider giving them subcut adrenaline as well in the arm. So maybe about 0.3 milligrams or 0.3 moles of an amp, and you just give it subcut. And what it does is it just works on the beta 2 receptors because it's slow release, and it just causes a bit of bronchodilation. It's the same thing that we do for asthmatic patients, but just not in the same dosages. So in an asthmatic patient, probably go 0.5, 0.6, 0.7. In a COAD patient, we probably just go to 0.3 and not more than that. So what you're trying to do is just trying to get them to a place of comfort. Now, this gentleman, from what I understand, because I tried to follow up with him, they did discuss him with cardiothoracics. The CT was done. It showed a complete rupture of the bullae over here, and actually it was almost linked to one of the well, not linked, but there was a bit of a leak from one of the major airways. So if we had inserted an intercostal drain, we would have had a drain that basically we could never remove. It would just keep on bubbling because there would always be air coming out from there. So by allowing it to consolidate and heal, you're basically then left with, yes, 3/4 of a lung, but at least a lung that's functional, as compared to a person walking around with a drain the entire time. And excuse me. And I think this patient was eventually, it would eventually be considered for a pneumonectomy. So maybe to remove that right lower lobe completely. I think it does extend into the mid lobe. So he'd probably have the middle lobe removed eventually if it was really severe. But I don't think the case has gone that far, as far as I understand. So yeah, just quite an interesting one. So our normal reaction in the emergency department is, we want to achieve homeostasis as quickly as possible. So we give the patients bloods, and we give them trips, and we give them everything to try and get them as close to normal as possible. So your first instinct on seeing something like this would be, let's put an IC drain, let's see what's happening. Now, if it's not trauma related, if it is COAD related, my advice to you would be, hold on, don't do that. Just wait, and let's just see what happens. Let's do a CT of the chest. Let's see how bad the rupture is. Let's see what else is affected, and then let's make a decision together with cardiothoracics. So what we would do now is that we would keep the patient on oxygen, make sure the sats don't go above. So let's just try and type that out here. All right. So what we're going to do is we're going to give O2. All right. Sats, sorry, that's me. So sats less than 92%. All right, let's just say 88 to 92%, with no ICD. All right, no IC drain. We're going to give a steroid. All right, so whatever steroid you have, I would suggest probably a hydrocort. All right, we don't want to give anything too strong. All right, and just give hydrocort. We would probably give them empirical antibiotics. I'm spelling it correctly. Nope. Empirical antibiotics. We'd also want to, if needed, let's just say subcut adrenaline. Right, but that's with the caveat that it's not really necessary most of the time, but you can think about giving subcut adrenaline as well. And yeah, then we would of course need a chest CT. Now, of course, if you're in an area where you can get a quick chest CT, great, go ahead, go and do it. And then we consult with medical and cardiothoracic. All right. So these are the departments that will make the final decisions on what to do. Medical because of the underlying COAD, and cardiothoracic because they need to decide on whether the patient is a good candidate for an IC drain, or whether the patient will need a pneumonectomy or some other sort of intervention in order to make sure that everything works out okay. All right, I hope you guys learned something from that. And next week, hopefully we'll have a few more tutorials. And again, thanks to the day team and Dr. at Madhureni for sending us this X-ray. Yeah, and yeah, hopefully we'll have another one soon. Keep well. Bye.